Yes, so at SOHO this year, I'm talking about holding and bridging therapy in patients with aggressive B-cell lymphoma. And I think it's important to differentiate, the two terms. So holding therapy refers to the treatment we give a patient prior to leukapheresis, so prior to cell collection, which can have a direct impact on T-cell fitness. So the goal is to avoid agents, mainly to avoid agents that can have a deleterious impact on T-cell fitness and on the product quality, which will then reflect on the product quality which we are infusing at time of CAR T-cell therapy. So I think it's important to avoid the use of Bendamustine prior to leukapheresis in the 9 to 12 months prior to leukapheresis, ideally. That's what the different studies in this area have shown. In terms of other agents which have sparked, concern in the scientific community, we have bispecific antibodies. In the lymphoma space, target is different. So they are CD20, CD3 targeting, CAR T cells are CD19 targeting, but still, there was a concern regarding T-cell exhaustion of the bispecifics and prior to CAR T. So we conducted a study looking at this and did not observe inferior outcomes in patients exposed to bispecifics prior to CAR T. Therefore, it seems safe to treat patients with CD20, CD3 targeting bispecifics, and after, a washout of 3 to 4 weeks, proceeding with the leukapheresis. And finally, the last, idea I wanted to share in the holding space would be regarding CD19 targeted agents, such as tafasitamab or the ADC loncastuximab. I think there's more questions than answers in this space because there are not lots of studies, not lots of data out there regarding patients treated with these CD19 targeted agents prior to CAR T cells. So just keep a watch out for that in the future studies and publications. Regarding bridging therapy, that's the treatment we administer after leukapheresis and prior to lymphodepleting chemotherapy and CAR T cell infusion. I think there the goal is different. The goal is to reduce tumor burden, which can increase the chance of a durable remission with CAR T cell therapy and decrease the risk of severe adverse events with CAR T cells. So we want to reduce tumor burden, but at the same time avoiding unnecessary toxicity with very intensive regimens. So the main regimens I usually use in the clinic are radiotherapy, single agent steroids, low-dose chemotherapy such as an R-GMOX regimen, or polar-based regimens such as Pola-BR if the patient hasn't been previously exposed to polatuzumab. Avoiding very intensive chemotherapy regimens and only using them if strictly necessary.